Hi, my name is Tripp, and I am going to be talking about palliative sedation in our talk about ethics today. So, palliative sedation, first of all, before I get too excited, let me outline what we're going to be talking about. So, we want to go over what is PS, right? The controversy. I'm going to go over a few case studies with you. We're going to talk about our current regulations and my personal recommendations, and then the rest is up to you. First of all, what is palliative sedation? So cancer.gov describes it as the use of special drugs called sedatives to relieve extreme suffering by making a patient calm, unaware, or unconscious. This may be done for patients who have symptoms that cannot be controlled with other treatment. Palliative sedation may be used in patients who are near the end of life to make them more comfortable. It is not meant, however, to shorten life or to cause death. So this is for those who have severe symptoms that cannot be controlled. PS is also commonly used in patients who want to alleviate extreme discomfort or pain. The three top requirements for this treatment is that the patient is terminally ill or near the end of life. The suffering is not helped by the treatment, any other treatment, and the intent is to sedate, but not for anything but to control the patient's suffering, not to cause death or to hasten it. So we're not talking about euthanasia or assisted suicide. We're talking about sedating someone's pain so that they can slip away. Now, the controversy, according to medscape.org, is that some experts state that they are less than confident that PS is even a beneficial source of treatment. There's just not enough information to be able to tell us whether or not it's something that will accelerate death or something that could even cause death, because those that could give us feedback are unconscious. Now, during a presentation in January 2005, Dr. William Shaver argued, saying, quote, "The ethical arguments for the use of palliative sedation for existential suffering may not satisfy the requirements for proportionality, non-maleficence, and intent." And now, let's dive into that a little bit and talk about it a little more. Let's start with autonomy. So autonomy is defined as a person's right to make their own healthcare decisions based off of their own set of values and beliefs. Now, suffering and pain is such an individual experience that it can only be defined as the person who is experiencing it. So I hope you see where we're going with this. Now, keep that in mind while we talk about informed consent. Right? It becomes a very complex issue when we think about the concept of autonomy. According to Medscape, with no clear and convincing evidence that the sedation actually controls symptoms of suffering, can a patient truly give informed consent? We have, again, no feedback telling us whether or not these people are actually receiving the treatment that they wanted, that they signed up for in the first place. The other issue with autonomy is that if someone signs their consent, they're also losing their personal autonomy in the sense that once they go under, they have no control over whether or not they're able to change their minds based off of their progress. They have no control over whether or not they are revived or brought out of this sedation. So the second that they use their autonomy, they lose it. So let's keep that in mind and talk about non-maleficence. Non-maleficence is the principle of doing no harm, and it revolves around a provider's promise of their Hippocratic oath, right? Any healthcare professional in their Hippocratic oath is to do no harm. Now, this applies to intentional or unintentional harm, and as we've already stated before, we still have no idea if palliative sedation is something that can cause or accelerate death. We just don't have enough studies or evidence to prove that, or to disprove it. And there are so many questions and arguments on both sides that it really just comes down to luck of the draw. Now, moving on to beneficence, this is the statement that health professionals will do what is absolutely best for the patient, no matter what. Dr. William Shaver suggested that palliative sedation may be more beneficial to family members than to the actual patient itself. How can you be able to assess if the PS is even working or doing what is best for the patient? How can you assess that when the patient can't give you his feedback? So you see where we kind of get into the same issues. So let's give some examples. There's a lot of examples out there of people who have tried this kind of sedation, this treatment, and it didn't quite go as well as they wanted to. But let's just give a hypothetical for now. Let's say a patient who is suffering from untreatable symptoms that cannot be treated by anything else. They've tried everything that they can, it's just not working. He signs an informed consent to be put under palliative sedation. Right, now let's say that his condition unexpectedly improves while he is under. So his family makes the decision to bring him back to consciousness. There are so many questions that can revolve around a situation like this. First of all, does the family actually have the power to be able to go above his consent and to bring him back? Of course, that would be what is best for the patient. But is that something that they have the ability to lawfully do? Let's say that they did, and what if he comes back, he doesn't want to be brought back? Maybe he had a DNR, maybe he decided he didn't want to be resuscitated, to be revived, he was ready to pass on. And that decision was taken from him because they overrided that informed consent. Now, if the same situation happened, and the patient improves, and because he signed up for PS, isn't brought back to consciousness. All right, so same situation, but let's say he isn't brought back. This person is now using hospital resources to be sedated when it's no longer necessary or no longer what's best for the patient. It could potentially put him in a situation where maybe he's in this coma-like state until his family can go over his head and rearrange that to revive him, or until he dies. So there's so many questions that revolve around this. It really ends up being the individual's choice, the family's choice, which is why under our current regulations, we have a system of palliative medicine teams. That word gets tricky after a while. But we have a palliative medicine team that should be involved anytime PS is even practiced or discussed. So according to the Mayo Clinic, our current regulations say that when it is available, palliative medicine teams should be provided and involved when PS is practiced, given their familiarity with advanced PS therapies if necessary. Palliative medicine physicians can consider consulting with other experienced colleagues, ethics consultants, and legal departments as needed for consensus when clinical circumstances are unique, i.e., when the patient or patient's family members or staff disagree about the use of PS. However, a routine involvement is generally necessary. Right? My recommendation, be informed. I think that is the biggest part. So because of that, I personally would recommend the use of an ethics committee to be able to describe to the patient and to his family, his or her family, what palliative sedation actually is, so they can get multiple perspectives. They can get a better understanding of what it entails and some of the pros and cons that we've discussed today. Before I leave you with that, I do want to discuss one more case. His name is Russell Halbert. He was a 58-year-old male who had a 100 pack year history of smoking and developed COPD. Right? He presented to the clinic with a feeling that something was caught in his throat. He had difficulty chewing or swallowing. He couldn't move his tongue, couldn't articulate, and he had numbness in his tongue. Him and his family tried a number of treatments, and ultimately it just metastasized and ended up getting him to a point where, as this Stanford study describes, as a hypernasality and loss of tongue, which made the speech completely unintelligible. Extensive loss of the teeth coupled with the loss of the tongue made it very difficult to swallow. He had severe facial disfigurement and a necrotic, non-healing oral ulcer, which caused severe malodor and undescribable facial pain. Russ Halbert's symptoms were controlled, but after a while, it wasn't enough. He was on methadone 3 times a day. He was on morphine every 4 hours. He was on haloperidol for vomiting every 6 hours, lorazepam every 4 hours for anxiety, because it was so scary to him that these things were just destroying his life, right? Once he was admitted, the physician recommended looking into palliative sedation. Once the symptoms worsened and they couldn't be controlled, that's when the physician recommended PS. So after a meeting with his family, they decided that this is what they wanted. Now, days before this decision was made, the patient adamantly refused further surgery, refused chemotherapy and radiation therapy, and received a lot of support from his family, but he also signed a DNR, right? He did not want to resuscitate. He did not want a feeding tube. He did not want any of these things. He was ready to pass and to let this go. Right, and he actually had full support from his family. So over the next few weeks, as his symptoms worsened, he started in palliative sedation. So at first, he was not completely unconscious, right? He still was able to complain about pain. He was still able to communicate that he was not, in fact, sedated, and they gave him a higher dose. 4 weeks went by and he had to be medicated every 30 minutes with a cocktail of different medications, 6 or 7 medications. After 4 weeks, he passed quietly in his sedation. This is a very positive example, I feel like, of palliative sedation. This is a situation in which, if we're talking about what I feel is ethical, I feel like this situation, this case in particular, it was appropriate for the family and for Russell to put himself under this kind of treatment. It was a great way for him to be able to alleviate his suffering while he was in his final stages of life. But in any case, I highly recommend for the families and for the individual to have a plan, to meet with an ethics committee, to know the consequences and to know the benefits. They should be aware of everything that could possibly be of help to the patients. And it should be something that is resolved with an ethics committee along with the family and the patient himself. So that's my time. This has been a ethics discussion. My name is Rebecca Tripp, and let me know if you have any questions.